Welcome everyone. Thank you for joining the NAS Provider Video Series. This series of 4 videos was developed to increase awareness and understanding of adverse childhood experiences, prenatal substance exposure, medication-assisted treatment, and the impact on infants and their families. The development of this public education series is the result of collaboration between state agencies and community partners. This video discusses opioid use disorder and medication-assisted treatment and is presented by Michael White, Director of Community Programs at Community Medical Services. Medication-assisted treatment, or MAT, is one of the evidence-based treatment methods available for pregnant women who have an opioid use disorder. In this video, MAT treatment is described in detail, including the pros and cons of each type of medication and its effects on the brain, the impact of MAT treatment on the newborn resulting in neonatal abstinence syndrome, and the need for providers to work collaboratively to improve outcomes.
Hi, my name is Michael White. I'm the Director of Community Programs for Community Medical Services. I've been in the substance abuse field for about 8 years and children's services for 2. My master's is in criminal justice from Arizona State University, and I accidentally fell into supporting pregnant women through my judicial system partnerships of reentry services. So I'm here to talk to you today about pregnancy, opiate use disorder, and medication-assisted treatment. So opioid use disorder addiction is a chronic disease of the brain that is expressed through compulsive behavior within a social context. It is also a biopsychosocial disorder with many social determinants of health that can combat somebody's success battling that addiction. Opioid use disorder is a brain disease. We're looking at a brain scan right here with a control group, an opioid dependency agonist therapy group, and an opioid dependency sustained remission, proving that it is a brain disease. Medication-assisted treatment is oftentimes debated and historically debated by its efficacy and effectiveness as a first-line defense for opiate use disorder. The debate is over. There are multiple meta-analyses that prove the efficacy of medication-assisted treatment and should be utilized as such. There are 3 types of FDA medications that are currently used throughout the country. The first one being an agonist. The best example of that is methadone. All medications have pros and cons. We'll go through methadones real quick. Pros for methadone is access to treatment, meaning that I can start somebody even if they use that morning. So it's a really good medication to utilize for somebody just coming into treatment. It has 50 to 80% retention rates after a year. It is the gold standard for treating pregnant women with opiate use disorder. So that's endorsed by the World Health Organization and the American College of Obstetrician and Gynecology. Cons is it has a high potential for abuse, and access to treatment can be difficult as you need to get it through an opioid treatment program, and those programs tend to be heavily regulated. The other example is a partial agonist, which the best example of this is buprenorphine. Pros for buprenorphine is it's easier to access. Doctor just has to go through waiver training, and then they can prescribe to individuals with buprenorphine. It has 40 to 50% retention rates in treatment after 3 months. The research is increasing for the support of utilizing it for pregnant women, but FDA has not made a hard line on approving that yet. And it has less potential for abuse due to the naloxone in some of the buprenorphine medications such as Suboxone. Cons is it has to have a 24-hour detox prior to starting that medication. It has a ceiling effect of 32 milligrams, meaning that if I gave you 60 milligrams of that medication, it would do no more than the 32 milligrams that I would previously have gave you. So what this is to mean is that if I had somebody using 3 grams of illicit heroin every day, I might never be able to catch up to that morphine equivalent and then stabilize them with this medication. It can be highly diverted if there is prescribing of a certain amount of buprenorphine. That person could, in theory, sell half of their medication, then paying for their doctor visits with the other half. And treatment might not be comprehensive. And so this is to mean that OBOTs or sometimes office-based treatment providers do not have case management or counseling inside their facility. And utilizing these medications as a tool is very important, but even more important is that that long-term cognitive behavioral change and those changes from illicit or criminogenic activities. And so making those long-term changes inside your personal life for sustained recovery and avoiding relapse. The last medication approved by the FDA is the antagonist, and so the best example of that is naltrexone. And so naltrexone, the pros is it's non-divertible. Some of those medications come in film, or more popular, the injection. So it would be hard to illicitly divert your medication once it's injected in you. No abuse potential. It is not a controlled substance, which makes it a good response for rural communities, as any healthcare provider can really provide this medication. It's an option also for high-functioning clients, people with strong social networks, jobs that won't allow them to participate in other levels of treatment, etc. Cons is it has 15% retention rates after 3 months. Research is mixed on the efficacy. More research is coming out. The biggest hindrance I find with utilizing this medication is it takes 7 to 14 day detox needed before starting the medication. So somebody would have to be off opioids for 7 to 14 days, and it's $1,200 an injection lasting for 30 days. This is how those medications sit on the mu receptor inside the brain. As you can see, methadone fully activates it, buprenorphine kind of bubbles, and then naltrexone blocks it. It's important also to look at the ASAM levels of care, as opioid treatment programs are a level 1. Having been someone spending a lot of time in courts and other places, we sometimes adopt that alcohol model, and what I can tell you is substance abuse disorders are very different. Opiate use disorder will have high efficacy rates at a level 1, but I oftentimes witness judges or other people promoting a residential level of care, which is a level 3. And so what that means is that you're skipping 2 whole treatment levels to send somebody to a very strict level of treatment. And so it's important to distinct that medication-assisted treatment is a level 1 service and should be utilized before all others. Neonatal abstinence syndrome is the incident where a baby is born withdrawing from opiates because of mom's use of those opiates. And so it's important to note that the baby is passively exposed. It is not born addicted, as many newspapers would like to lead you to believe. They have no cravings for the drugs, and they've never been involved in illicit substance abuse activity. MAT, or medication-assisted treatment, will not prevent NAS from developing. However, compared to illicit use such as heroin, it can reduce maternal morbidity and mortality. It'll reduce the likelihood of withdrawal-induced miscarriage or premature birth, and promotes fetal stability. It also provides mother with stability as a safe place. Them being involved in treatment provides them support and also daily accountability. Complications for children being born with NAS are low birth weight, jaundice, long hospital stay, morphine treatment. However, that's tending to go away due to new pilot studies and treatment that are trying to find more natural treatments. Increased risk of neglect and accidental death. Research shows behavioral problems in children who experienced NAS as newborns also. However, there's an asterisk because oftentimes environment can play a more major role in those studies. Right now we're looking at a slide of NAS in Arizona. As you can see, in 2008 we had reported cases of 1.52, and now in 2017 we have reported cases of 7.53. Some of this information is coming out because of Governor Ducey's executive order in June of 2017, so we're really, as a state, tracking these data of opiate deaths or overdoses in a better way, along with neonatal abstinence syndrome. This is a snapshot of NAS around the country. This is a little trifold from NIH that says a baby is born every 25 minutes withdrawing from opiates. And on your right side, it is showing a national map of blue to black, demonstrating the rates per 100,000 of NAS. It is also important to note that medication-assisted treatment can help with the reunification process for Department of Child Safety. I'll ask you to look at the fourth bullet point down. However, there's multiple amounts of research out there on Google Scholar that you can become curious and engage with yourself. But parents in opiate substance abuse treatment were 70% more likely to be permanently reunified compared to a family not enrolled in MAT. Important aspects of supporting pregnant women during this complicated process of pre and post birth is trauma-informed care, wraparound services, as we often work in our own silos and don't partner with other agencies that might better help the outcomes of the families we're serving. Families first, support groups, mentor groups, so moms supporting moms. Peer support, same kind of principle where people who have gone through this situation themselves can then turn around and support those parents. Pregnancy plan through the hospital, having a safety monitor at home, making sure that the parents are safe with their child, and then interaction with hospital and staff coaching. It is also important, we are very lucky in Arizona to have therapeutic courts for families, or family therapeutic courts, in the form of Cradle to Crayons and the Shift Collaborative. One aspect I mentioned earlier is working in silos. And so it's important we as a community support this mom through the whole continuum of care of having this child. And so it's important that we understand that we're all working from a common agenda. We're all trying to have safe Arizonans and trying to protect those children born in these circumstances and supporting the mother to be as successful as she can be. So what we want to do is start collecting data and measuring results consistently so we can make evidence-based decisions, making sure that what we're doing is the right thing that we're doing. We also want to have a plan of action for mutually reinforcing activities. I speak to a lot of moms that go to 7 different providers and they have the same conversation, so we could complement each other instead of working against each other. And we want to have continuous communication. And so one thing that's helpful for us is email chains with all those system partners on that email, so we can update each other at the time of information being needed. And then in that, we need a backbone organization to kind of monitor and project manage that family. During the Obama administration and the Trump administration, STR, state targeted response grants, and state opioid response grant funds were distributed to states. The state of Arizona did something very innovative, and what they did was open the country's first opioid treatment on demand site. This is also known as a Center of Excellence. It is amazing what this complex has done since opening on October 2nd, 2017. Since that time, it has done over 5,300 intakes outside normal business hours, supporting hospitals, police, fire department, Department of Corrections, jails. It is probably one of the most supportive agencies or supportive clinics that can get people into treatment exactly at the time they need it. Oftentimes these individuals have one small moment of motivation and now they're able to capitalize on that. These are the residentials currently accepting MAT or medication-assisted treatment. They are very good system partners and work really well with other agencies. It's important to note that LifeWell, Hope Center, and Sally's Place support pregnant women. These are also some helpful contacts. If you ever have a general question or need to verify dosing, CMS on-call nursing 24/7. Also labeled here are 2 other doctors and providers in the area, so an outside perspective. If it was up to me, the most important takeaway from my PowerPoint today would be that we seriously need to quit working in silos, and we need to start working and supporting these families, not only families, but opiate use disorder in general as a collective. My agency doesn't have all the services, a hospital doesn't have all the services, Department of Child Safety doesn't have all the services or the answers, and I think all of our other agencies need help from the other agencies to improve outcomes for these families. So if you're going to take one thing away, my encouragement to you would be to get out of the office, take meetings, learn what other folks are doing in the community so we can really support these families through the whole continuum of care from pre-birth to post-birth. How do we get services to a mother that just found out she was pregnant? And then how do we follow up with those services when the child's 2 and 3 years old? And so that takes a lot of different agencies to be able to accomplish that. And my dream in all this is that all those agencies step up and we start doing it in a different way.